Hi, I'm Glenn Healy from the NHL Alumni Association. We hope all of our hockey family are safe in this time of COVID-19 as we enter what is unbelievably the third month. We have a support team to help if you need help. We have a social worker, Jerry Jamaka. If you need to talk to him 24/7, give him a call. We have a mental wellness team put together that will help because these are trying times. But our most important person, our rock star, our medical leader, so to speak, our chief medical officer is one of the world's most renowned neurosurgeons, Dr. Amin Kassam. And there are so many mistruths about this virus, and there are so many things that we've heard, whether it's in the media, whether it's stuff we've read on the internet. Well, we'd like to put together a video with one of the chief medical people, our chief medical officer, to tell you what this disease, this virus, is all about, how long it lasts, how long it will take to get a vaccine, and what we're looking at in our future. So I would like at this point to pass the puck off to our Chief Medical Officer, Dr. Amin Kassam. Amin, take it away and tell us some of the truths.
Thanks, Gil. Hi, everybody. Real pleasure, and I'm sorry we're having this conversation over such a difficult time, but pray that everybody's family is well and safe. Just as we move forward, the intent of this is to be able to share some broad concepts with you. And if you need help, this is not intended to be medical advice. Really do need to get to your family physicians or urgent care facilities as you need. I'm going to try and address a lot of the commonly asked questions around COVID. And what is it? How is it different? Why is this not the flu? What's unusual about this? So our team has spent a fair bit of time looking at this question, and we've been asked about it a lot. When we try and compare COVID to the other things and other pandemics we've seen in the past, what we notice is, first of all, it's very different than the seasonal flu. So this is a graph. The y-axis that you see shows the mortality rate. What that specifically means is as a portion of the population, how many people does that particular pandemic or infection kill? The bottom, the x-axis, the horizontal axis, looks at not how many people the virus kills, but actually how many individuals can one individual infect. In the medical term, that's referred to as the R0. So what you see here is seasonal flu doesn't kill a lot of people. Its mortality rate is actually quite low. It might be somewhere less than half of 1%, maybe closer to 0.1%. And the number of people that it infects isn't as much as many of us thought. It's actually less than 1%. So for every individual that's infected, the number of people that you're contagious to and can infect, less than 1%. When we compare that to Ebola, it's very different. Ebola can infect 2 people, and an individual in general has an infectious rate of 2 times, an R0 of 2. The other difference is that Ebola, if you get it, it has a mortality rate of 50%. So what that means is it's got a very high mortality rate and a moderate infection rate, R0 of 2, and a mortality of 50%. In comparison, when we think about something like smallpox, it has a much higher infection rate, an R0 of 5. What does that mean? It's an individual's ability to infect is 5 times, almost 5 times out of the flu. And the mortality rate is still pretty high at 30%, not as high as Ebola, but still pretty high. The reason this is really important is as Ebola and smallpox go out into the community, they can infect a lot of people. But the individual that's the carrier, the person that's transmitting this at a rate of 2 and 5 times, generally doesn't survive to the same extent as somebody with the flu. So in fact, in many ways, the disease runs out of hosts much faster than it does in something like seasonal flu. Polio looks a lot like smallpox. It has an infection rate of 5 times and a mortality rate of 20%. SARS that we saw most recently is somewhere in between. It has an infection rate of about 3.5 times and a mortality rate of about 10%. And you can see why these conditions were contained, because of the relatively high mortality rates that essentially the infections ran out of hosts if we left them long enough. Spanish flu was very, very different. Spanish flu has an infection rate of about 2.5 times, but its mortality rate was much lower than Ebola, smallpox, and SARS. It was in the order of about 1%. As a result, it could infect a lot of people. They would carry the infection and infect 2.5 times as the number of people. And it didn't run out of its host, because if you had it, you had a 99% chance of surviving. And while you're surviving, you had the opportunity to infect 2 to 2.5 times more people. So it kept feeding itself. And that's why the total mortality associated with it was so high. When we look at COVID, it fits more of a pattern of Spanish flu. Currently, there's a lot of debate on what its actual mortality rate is, how many people actually die. The reason there's debate around that is because we don't know how many people that actually have it. So in order to calculate a rate, you have to have the number of total people that had it versus the number of people that passed away. And we don't have that bottom number. As best we can estimate, it's in the order of about 1%. What we do know, its infection rate is pretty high. It's at about 2.7 times. So much more much more probability of infecting other people than the flu. And a mortality rate that currently seems to be significantly higher than that of the flu, at about 1%. Some of the recent data in the modeling that have been done have made estimates of how many people it will actually kill. And those are being revised on a monthly basis because there's a lot of changing data. The concern is, if COVID was left to its own, given how many people it can infect at 2.7 times, and as those people go out into the community, the likelihood of survival at being more than the Spanish flu at about 1%, but substantially more survival than Ebola, would wind up with an overall mortality rate that would be very, very high. What that means is that left on its own, it would be unlikely to run out of hosts, unlikely to have the pattern of Ebola with its high mortality rate, and would devastate our population. And these are the fundamental differences between the different pandemics that we've seen. The closest we can correlate COVID to is the Spanish flu. So we should learn from those lessons. When we looked at cities historically in the 1918, different cities took a different response to Spanish flu. Some cities took on social isolation early and hard and really didn't have a second peak, as you see, like Philadelphia. Some cities took on social isolation, but then relaxed, like San Francisco, and wound up having a second wave. Other cities, like St. Louis, took on social isolation, relaxed relatively early, and as a result, they had a significant second peak, as you see. Now, that's not to say this will happen with COVID, but we should learn from what we've seen with Spanish flu. So what this tells us is the timing of social distance matters. There likely will be multiple ongoing waves, and understanding that there's a certain level of uncertainty. And we've learned that from the past. So what can we do about this? What are our opportunities? This is just a theoretical timeline. We can develop a vaccine. Often we're asked, why does it take so long to develop a vaccine? What is a vaccine? A vaccine, in essence, is a portion of the actual virus that is taken as a form of it and packaged to the patient. And the patient then develops a response to the actual virus. This is a pretty significant tightrope that we walk. That tightrope means that you give enough of the virus to the patient or its components so you can develop a response, but not too much of it that it actually harms the patient. So to develop a vaccine is complex. It would be pretty difficult to imagine how a vaccine could be developed over the next 2 quarters. That would be hard to understand. But even if resources were deployed, we might be able to accomplish that. It's not enough to develop the vaccine. What we now have to prove, given that it potentially has a vaccine, has a lethality associated with it, we have to then figure out a way in which we can test it. So in addition to the first 2 quarters of deployment, we then have to undergo safety and testing. We have to give it to a small number of people, then we have to give it to a larger number of people, and then yet a larger number of people, each time showing incrementally that we're creating safety. And that can take another 2 quarters. So it would take, in my estimate, a minimum of a year to get to a point where we would have enough data to be able to then use it as a general therapy. And then we have to start manufacturing it. In the case of the US, in the order of 300 million, so we can start giving it to people, deploying it. It'll take some time to reach everybody, get the manufacturing and resources to be able to deploy. And that would likely take another 2 quarters. That would be about half of the population, at which point we would be ready to deploy to the other half of the population. And that would get us to a point where we would have created a certain level of immunity within the overall population. I believe it would likely take an act of God, and we pray that we get one, to get development, safety and efficacy, half the population, and then the other half of the population fully immunized in under a year. That would be a remarkable and historical accomplishment. But North American ingenuity has always surprised the world. Let's pray that that actually happens. While we're waiting for that year, what would we see? The number of carriers, the number of people that are infected would be escalating and eventually plateau. Initially, we would see a rise in the number of cases. What we did in the month of March and April and May protected us. It kept the number of carriers out there that could be infecting others at a rate of 2 to 3, the doubling time associated with this, down to a minimum, to the social isolation. And that gave us the protection we needed. As we then undertake relaxation and what we've learned from the Spanish flu in history, there is a high probability as those that are carriers now start to circulate, will start infecting additional people. And a subset of those will start to develop symptoms. And you may very well see a second peak. We're hopeful that we can mitigate that second peak. We can reduce its effects through a variety of different ways. And this is a race against the second and potentially the third peak, against the time that it's going to take to get the vaccine developed, deployed, and everybody immunized. And that's the race of time that we're going to be trying to manage over the next 12, 18, 24 months. So this is a long-winded way of saying this is not something that is likely to go away in a quarter. This is likely going to be with us for a couple of years in various different forms. What can we do about it while it's with us? There are really 3 major strategies. One strategy is social distancing. What does social distancing mean? It means keeping carriers away from those that aren't infected. We can do it completely, which really requires that we essentially create the current lockdown situation. Or we can do it partially, or we can let people out in groups incrementally. What are the differences and what are the concerns with partial? The challenge with partial is really threefold. One, we don't know exactly who's infected. Even with current testing paradigms, our ability to test, there is a false rate that's real. Some tests have shown that to be 15%, even if it's 5%. If you think you have it and are protected, or you think the person you're about to come into contact doesn't have it, you would be more likely to pursue partial isolation. You might go to a party, you might go to a bar, you might have family over, if you had faith in the testing. If there was a chance that the test was somewhere between 5 and 15% of the time wrong, and you think you're being exposed to somebody who doesn't have it, but actually 5 to 15% of the time actually has it, that's a pretty big risk for the following reasons. One, it goes back to the likelihood of that person infecting people around them. That likelihood is 2 to 3 people for every one person that's exposed. That creates a doubling time in the order of days. 2 is the individual, unlike in Ebola, who's positive, may very well be asymptomatic. In Ebola, that individual had a 50% chance of not surviving. Whereas in this model, that individual who doesn't know whether they have the disease or not, because the test could be wrong between 5 and 15% of the time, will be out there unknowingly infecting between 2 to 3 people on every contact. And you can't isolate that individual. That's the risk of the partial isolation model. To summarize, the risk is the testing is not 100% accurate. It has a relatively high rate of infecting others and a very high rate of survival, which creates a situation that the condition can keep going and going and going from a virus perspective. The other challenge is the availability of testing. If we could test every individual in the US, which is what would be required, we would need to test about 300 million. If we could test 1 million people a day, 1 million people a day, that would require 300 million people to be tested over a year, essentially, 10 months. And the magnitude of this is what really creates the challenges. So that moves us to the second thing we can think about, which is therapy, drugs. There's a lot of discussion and conversation around the role of antiviral therapy. Antiviral therapy is analogous to antibiotic therapy. In the case of antibiotics, you get an infection, a bug, you treat it with an antibiotic. In the case of a virus, you get a therapeutic that treats the virus. The antiviral therapy is immensely important and vital to the future. It can help us manage the severity of the disease, how many people die from it. What it doesn't directly do is to stop people from infecting one another. So in theory, it could create a chronic condition where people are surviving longer, God's grace. They're not having the severity of the diseases, which is a tremendous blessing, but yet continue to infect one another in the population. The only meaningful way to really protect people is a series of immunizations. And there's 2 ways we can immunize people. Either they get the condition and they naturally develop immunity through exposure and not passing away and not having severity. That requires this concept of herd immunity. That would mean that somewhere between 60 to about 80% of the population would have their own antibodies, their own natural mechanisms to be able to fight the virus. And that's going to take time, and we'll lose a lot of lives if this were to occur naturally. We can accelerate that process by delivering a vaccine, which is a portion of the virus that doesn't kill people, but develops antibodies to protect them, to see if we can reach that same 60 to 82% coverage that we need to get the immunization we're needing. And as we just talked about, it would likely take an act of God to be able to have that available and immunize the nation in under a year. But in times like these crises, it's exactly the act of God that we need. So the question then becomes, what can I do now while I'm waiting for that act of God? There are definitely things we can do. And how do we know? Because we know that from the past pandemics, and in particular Spanish flu. So the single most important thing that we know we can do is you can wear a mask. Why is that important? Wearing a mask, and this is important, does not protect you as an individual, does not protect you as an individual from getting COVID. The size of the COVID particle is so small that through conventional masks, it can work its way through. What it does is it reduces the viral spread from you if you have it as a carrier to people around you. It contains a number and volume and amount of virus that you might spread. So this is one of those situations where what we do each individually can actually help each of us together. The second thing we can do is really focus on our own individual mental health and support. It is normal. In fact, it would be abnormal and unusual for us not to feel the effects on our mental health, on our wellness during these periods of prolonged isolation. It would be very unusual for us not to feel that. One of the goals of the trial that we were trying to really focus on last year when all of this began was to really focus on individuals' mental health and make sure that they had support through a variety of different measures. And I think everybody should know that the entire field of medicine, its study, its design, its trial worldwide has come to a grinding halt, like many things with COVID have. This will change the way we practice. We fully intend to figure out a way to be able to pivot on this trial, as Heal said, and to be able to support you. And we're using our resources actively to develop perhaps a much more robust way of doing that, using technology to be able to do so. In the meantime, each of you will, should, and have experienced mental health challenges, depression, isolation. That just means you're normal. And getting the support mechanisms you need is key. So there's several things that the Alumni Association has done. One has been the development of this alumni resource team, which is person-to-person contact. Obviously, we can't continue that in the new COVID world because of the conversations we had around social distancing. What we can do, though, is to provide support to the extent that we can. Heals has been able to put together, through the support of Ken Nash and others, a social worker who I understand has made a significant impact within the association already and is accessible. We're trying to think about how we can use digital and teletechnology to be able to support you. But the truth is, the support really requires two things. First and foremost, it requires each of you to support yourselves, building structure back into your lives, getting up at the right time, doing the things that you normally should be doing, keeping on your routine, eating the way you normally should eat. And then really, and I think this is why the Alumni is so unique compared to anybody else, the best form of support that you can get is each other, is the ability to support one another during these periods. You all as ex-teammates and athletes are used to this, whereas the rest of the community doesn't know how to use its team around it. And I'm very optimistic that actually you'll support one another. What does that mean from a day-to-day perspective? It means that a day should not go by when you don't individually pick up the phone and call 5 people. A day should not go by where each of you shouldn't connect with 5 others in your network. It's the rule that I live with on a personal basis, and my family lives with. So we try and reach out to 5 people every day Sometimes they're the same and sometimes they're different. Because in a day, when I walk through my day, I probably reach out to 50. And I could touch 5 and hear from them for a variety of different reasons. At least I'm getting that kind of interaction that I need. I think the second thing is everything that you're doing, you need to pause and think twice about why you're doing it. Because during these periods and lack of structure, it becomes easy to fill old habits and distractions with new ones. And that's a common thing. A void gets created and you fill the time and the emotions with new habits. And as you're filling them, think about what you're filling that with. Are you filling it with something to occupy your time or your mind or to help you with your mood? Because in doing that, you're going to create a new habit. And can I create a new habit like calling 5 people? Like connecting with people that I haven't been able to connect with? Like writing about something that I want to write about, or reading? And just fill your habits with new habits. And the last thing that we can do on an individual basis is to protect those of us that are at higher risk. And that's really important. In this particular population, it's very important. This is very true, is that this virus affects people differently. And we're only learning about the effects of the virus. Right now, our focus has been on the effects on the lungs and the breathing systems. And we know that people with less reserve are more impacted. We've considered pre-existing conditions. We've considered issues around age, medications, and those are true. And those are real. And to protect high-risk individuals from being exposed is probably the most important thing we can do. Lastly, we're also learning that this virus is not a single event. It affects different organs differently. And we're now starting to see the effects on the other organs. More recently, we're learning about how this is affecting blood vessels. It can create strokes in the brain, blood clots in other organs. So the virus is much more than just the simple flu. On the basis of the different organs it can affect, on the basis of the severity of the organs, and on the basis of its survivability. I'm glad that you have each other, and I'm very glad that you have HEALS to support you through this process. I see many people and a lot of different organizations that don't have those resources. So stay safe and stay well.